Hi, this is Ramesh Papanna, Professor and Director of Division of Fetal Intervention at UTHealth Center in Houston, McGovern Medical School. We would like to take some time today to discuss a recent publication of our experience of prenatal open repair for the management of fetal neural tube defects. I'm here with Dr. Cliff Brock, is our previous fellow in fetal intervention who graduated in 2022. Now he's attending in fetal intervention at Midwest Fetal Care Center in Minneapolis. This is his labor of love. Spent a significant amount of time during his fellowship to better understand the Hindbrain herniation reversal in utero repair. So the publication is titled "The Significance of Hindbrain Herniation Reversal Following Prenatal Repair of Neural Tube Defects," and it was published earlier in this year in Journal of Neurosurgery, Pediatrics. So Cliff, welcome, and what is this paper about?
Well, thank you so much for having me and for the opportunity to discuss our work. So, as you know, myelomeningocele and myeloschises are among the most common non-lethal anomalies of the central nervous system that can be diagnosed on prenatal ultrasound. And these defects are caused by a failure of the neural tube to close early in pregnancy and result in an opening in the spine with exposure of neural tissue. And you can see that in this picture on our slide here. The defects, myelomeningocele and myeloschisis, are a subset of what we call neural tube defects, and those are the ones we're going to be talking about. So they cause considerable morbidity, including impaired sensory and motor function in the lower extremities, impaired bladder, bowel, and sexual function, and complications related to hydrocephalus and cerebellar compression. So prenatal repair was shown to reduce some of these morbidities, namely the need for surgical management of hydrocephalus and lower extremity function. And this was first shown in the landmark MOMS trial, which was published in 2011. So prenatal surgical repair of appropriately selected patients has become the standard of care at this point.
Well, thank you. So how does Hindbrain herniation fit into this paper or picture?
Sure. So myelomeningocele and myeloschises are almost universally associated with what we refer to as a Chiari-2 malformation. And basically, a Chiari malformation is when the cerebellum or hindbrain herniates through the opening in the base of the posterior fossa of the skull. This is a kind of an orifice. It's called the foramen magnum. On the MRI here, the red line shows the boundary of the foramen magnum, and you can see that the cerebellar vermis and tonsils, which normally rest in the base of the skull above the foramen magnum, extrude through this orifice, ending up in the upper cervical spine, and you can see that on the MRI here. So prenatally, the Chiari malformation can be detected on ultrasound as well as fetal MRI, and very interestingly, prenatal closure of the defect results in reversal of hindbrain herniation in many cases, either partially or completely, and this change can be detected on imaging after surgery.
Thank you. So before we get into the details of the paper, can you tell us about the bottom line of your findings? How does this relate to potential patients as well as the referring physicians considering sending patients for prenatal repair?
Well, so in this study, our primary finding is that reversal of hindbrain herniation is not clearly associated with whether or not progressive ventriculomegaly will require surgical management. And so by surgical management, we're basically talking about a procedure that diverts cerebral spinal fluid, or CSF, out of the ventricles because they're either too large or under too much pressure. This is accomplished by a pediatric neurosurgeon, either by placing a ventriculoperitoneal shunt or performing a procedure called an endoscopic third ventriculostomy. So we can refer to these procedures collectively as CSF diversion surgery to make it straightforward. And we can talk about the underlying indication as shunt-dependent hydrocephalus. So in our study, we do see a trend in the direction of reduced need for diversion when the hindbrain herniation has reversed, but it's not a strong enough association to be conclusive. So from a patient perspective, I think the most important consideration is how to contextualize the counseling that they are receiving from their fetal team. So hindbrain herniation reversal is often presented as a benefit of surgery, and it may well be, but at least with regard to hydrocephalus, we still don't fully understand the relationship. In our study, there are cases with complete hindbrain herniation reversal that still needs CSF diversion, and those without reversal that are able to avoid CSF diversion. So when a patient receives the results of a postnatal MRI with hindbrain status on there, kind of one way or the other, understanding that there's still a range of outcomes is important. And then for physicians, I think our study helps contextualize hindbrain herniation reversal. It's obviously very satisfying as a surgeon to see restoration of normal anatomy, but I think at least regarding hydrocephalus, the width of the lateral ventricles at initial ultrasound evaluation remains the most powerful tool for risk stratifying patients regarding hydrocephalus related outcomes. And I think the relative contribution of hindbrain findings should still be interpreted somewhat cautiously.
Okay, great. Now let's get into the details of the paper. Let's talk about the reversal in a little bit more detail.
Sure. So Chiari malformations, when severe, can result in a variety of symptoms. So those are things like headache, nausea, vomitings, problems with swallowing, hearing, balance, etc. Sometimes this requires a postnatal operation to decompress the cerebellum. However, in the case of a myelomeningocele, less than 5% of Chiari malformations are severe enough to require a decompression of the cerebellum. But the question comes up, could it be that hindbrain herniation reversal, so when the hindbrain comes out back up into the posterior fossa, that then reverses CSF obstruction, which then leads to a reduction in the need for surgical management of hydrocephalus? That's the question. So hindbrain herniation reversal and shunt placement, right, a ventriculoperitoneal shunt, were both reported in the MOMS trial, but weren't really directly compared. So some authors, some researchers have subsequently reported an association between these two things, but there are only a few studies. So what we wanted to do is evaluate whether this association between hindbrain herniation reversal and shunt-dependent hydrocephalus was present in our patient population.
Okay. Is there anything different about our patient population compared to these publications?
Yeah, so well, we're in the middle of Texas, and there's a huge multi-state catchment area, and many of our patients have prenatal surgery in Houston and then deliver at a local hospital where the decision to perform a CSF diverting procedure for hydrocephalus is determined by a local neurosurgeon, far away from where they had fetal surgery. And postnatal MRIs in the same way are also read in most cases by a local radiologist. So in one of the larger of the kind of previous publications that address this question, far more patients, like around 90%, were managed postnatally at the same tertiary care center where the fetal surgery was performed. So that's one of the big differences, in addition to just location. So there are a couple of publications out there that kind of get at this question, but not really in a population like ours.
Right. Okay, let's get into the details of the study then.
Okay. So this study, just to start off, includes only open repairs. So UT obviously now has a very successful fetoscopic program, but it's only a few years old. So we didn't include fetoscopic repair in this particular study, as the surgical technique is very different, and it would be difficult to adjust for that, and it would be difficult not to confound the study. So we had historically 98 patients that underwent an open repair at our center between 2012 and 2020. And we included those that delivered before July of 2020 because we did most of the analysis in 2022, and you need to wait a year to get postnatal follow-up for discussion of our primary outcome. So we excluded patients that were lost to follow-up, where the baby died postnatally or didn't have a postnatal MRI, or did have an MRI where detailed analysis of the hindbrain was not performed and images weren't available. So after those exclusions, we were left with 78 patients. And then we compared patients that had hindbrain herniation reversal to those that had persistent hindbrain herniation. So the presence of hindbrain herniation was determined using the first postnatal MRI. For patients that delivered at UT, images could be reviewed. However, for those reviewing elsewhere, which is actually slightly more than half, the MRI report was used. And we considered hindbrain herniation as a dichotomous variable. So the lowest aspect of the cerebellum on MRI was either above the foramen magnum or below it. And that's how you determine. So you can see this example on the slides again, the red line is delineating the foramen magnum, and the reversed hindbrain herniation is on the left, whereas you can see that there's persistent hindbrain herniation on the right-hand side. So that's how we considered that variable.
What outcomes did you consider?
So the primary outcome was CSF diversion, either via ventricular peritoneal shunt or endoscopic third ventriculostomy in the first year of life. We did consider several secondary outcomes. So those include CSF leakage, repair dehiscence, diversion surgery prior to NICU discharge, and a composite morbidity.
What did you find?
So the rate of CSF diversion was 42.1% in patients with hindbrain herniation reversal and 57.5% in patients with hindbrain herniation persistence. So you can see here in this bar graph on the left-hand side, the trend doesn't reach statistical significance. The p-value is 0.17. For the secondary outcomes, have a look at the bar graphs on the right-hand side, and a similar trend was noted in each of the secondary outcomes. So CSF leakage, repair dehiscence, diversion prior to NICU discharge, composite morbidity. These p-values for the comparisons kind of range between 0.26 and 0.62, so not quite meeting the level of statistical significance, but clearly a trend. So we also performed a multivariate analysis. So these are logistic regression models for each of the outcomes. And essentially, you're seeing a similar trend. So the results are laid out in this table, and you can see that outcomes are listed vertically on the left-hand column, and then the independent variables that we considered are listed across the top row. So the only variable clearly related to the need for CSF diversion in the first year of life was the initial lateral ventricle width. So this was true for diversions performed either in the first year of life or during NICU admission. And this association, it's shown on the left in the odds ratios that are bolded on the left-hand side. This is something that's already known to be true based on secondary analysis of the MOMS data. For the primary outcome, the kind of variable of interest, hindbrain herniation reversal, had an odds ratio of 0.39 in our logistic regression models, but the confidence interval did cross unity, so it was not a significant finding. You can see that result bolded on the right-hand side of the figure.
Yeah, definitely. This surprised all of us. We thought the hindbrain herniation reversal means they have, the need for a shunt is pretty going to be very low, or outcomes will be better. But it seems like they are relatively, slightly better, but doesn't meet the, what we call statistical significance. So, were there any difference in this timing of CSF diversion or type of diversion performed between these groups? Is there any difference?
Yeah, so for patients that required CSF diversion, the groups were similar with procedures performed at a median of 55 days of life when there was persistent hindbrain herniation and 79 days of life with hindbrain herniation reversal. So the p-value is 0.15. Again, you can see that there's a trend, but not quite meeting significance. Diversion by endoscopic third ventriculostomy was more common in the group with hindbrain herniation persistence at about 25% compared to 13.2% in the group with hindbrain herniation reversal. So there was a difference in the procedure performed.
Any other differences that you noted?
So interestingly, the group with hindbrain herniation persistence delivered about a week earlier at 35.5 weeks gestational age. This appeared to be related to a slightly higher rate of preterm contractions and preterm premature rupture of membranes in that group. I think this is unlikely to be related to the actual hindbrain herniation status, obviously, and is more likely an occurrence of type 1 error related to something else that we're not measuring.
Okay. I mean, every study has some limitations. So what do you think are the limitations of our study?
Sure. So there are a couple things to discuss there. one of the challenges of any study of fetal myelomeningocele or myeloschisis repair is that the postnatal decision to operate for hydrocephalus is made local to the patient. So I kind of mentioned this before, but a patient may undergo repair at a fetal center and deliver 100 miles away. And there's considerable variation in practice between neurosurgeons as to when surgery for hydrocephalus is or isn't recommended. And we have to consider this anytime, ventriculoperitoneal shunt or endoscopic third ventriculostomy is examined as an outcome. So I did attempt to kind of address this in our study with a subset analysis of only those patients that delivered at our center, which was a group of 30. And the findings were identical, but this is obviously a small number of patients to draw conclusions. Another consideration is type 2 error. Okay, so we do see this trend between hindbrain herniation reversal and CSF diversion, as well as other outcomes thought to be related to watertight closure. So you have to ask the question, is there something there and we're just not seeing it? Or we're seeing it, but we're not proving that it's, kind of conclusive, so to speak. So it could be that we just don't have enough power clearly to detect the difference. However, there's clearly more to the story than this with hindbrain status, right? So we see patients with complete reversal that nevertheless require a shunt and patients with persistent hindbrain herniation that don't require diversion. And it's also notable that if you kind of look at the literature, the reported rates of postnatal diversion surgery have been pretty stable since the MOMS trial, but centers have reported increasing rates of hindbrain herniation reversal. So clearly more work is required to better characterize what hindbrain herniation reversal means in functional terms. And finally, we treated hindbrain herniation reversal dichotomously based on the data available in MRI reports. Having a more nuanced assessment of hindbrain herniation, including the degree of reversal, would have been interesting, and it's certainly something we could, explore more in the future.
Great. Looks like we put the hindbrain herniation right at the center of the table, looking at it at all different angles. How do you think this study contributes to overall understanding of clinical relevance of hindbrain herniation reversal?
Sure. And so we, touched on this a little bit in the beginning, but it suggests that story's a little bit more complex. There doesn't seem to be a clear relationship, this kind of that you would want to see where, hindbrain herniation reversal leads to improved drainage of CSF. This is followed by a lower risk of requiring CSF diversion. That's clearly not the case in all cases. There's more to the story. So next, kind of as I mentioned before, I think the study is helpful for contextualizing hindbrain herniation in patients that are situated far from a fetal center. And this is really a substantial proportion of patients, certainly at our center, and I think nationally. How much does the postnatal MRI from their local hospital tell them about the probability of requiring a shunt over the next several months? I think we have to be careful about how we talk about this when we counsel patients. Also, a lot of centers now are moving towards minimally invasive or spedoscopic procedures, which are great because they're thought to reduce maternal risk. And it takes at least 30 months to observe the kinds of outcomes reported in the MOMS trial, which you would want to report on with a new procedure. So there's a strong incentive for people to consider short and medium-term outcomes as they develop these techniques, which are quite different across centers. So hindbrain herniation reversal has been one of these outcomes, and I think it's worth considering, but given that we don't know kind of all of the details, it should certainly be taken in context to other findings being discussed.
I think that's the most important thing. I agree that we got to be careful in saying a short outcome almost is a surrogate for a long-term outcome, not knowing these details. So this is a phenomenal finding in understanding of spinal bifida reversal of hindbrain herniation for a future, for more research to come. Thank you so much, Cliff. This has been wonderful discussing this paper with you again once more.
Thank you so much. I really appreciate the opportunity and had a great time talking to you.